Hello and welcome to this Your OT Tutor Connector webinar. This time we are talking about understanding the multidisciplinary team. So all the different team members that we might be working with as an OT. We're going to have a little chat about what their roles are, instances where we might be referring to them or where we might actually need to do a joint session with them as well. And then we'll talk about some general strategies to try and do your bit to make that team run efficiently and smoothly, and also maybe what you should do if there's a bit of a challenging situation dealing with some other team members. So we'll try and get through this as quick as we can, and then there'll be a little bit of homework at the end for anyone that wants to do some extra activities as well. But first, I'd just like to acknowledge the Quandamooka people, who are the traditional custodians of the lands, winds and waters where I'm situated to provide this session today. And I pay my respects to elders past, present and emerging, and acknowledge all Aboriginal and Torres Strait Islander people present today or watching the recording. So what are we going to cover? So we'll be able to talk through the typical roles of an allied health clinician. I'm also going to put in, I didn't add it in there, but we'll talk about nurses and doctors as well. Identify when it's appropriate to refer to other disciplines, including completing joint sessions, outline some strategies for working effectively within that multidisciplinary team, and then describe strategies for managing the challenging situations, such as when your treatment goals maybe don't align with what the other team members want to do, or maybe if you believe a clinician is actually doing something that's causing harm to the client. So what we'll do, as always, I'll start with a little bit of a session in a nutshell. This is like the 2 or 3 minute version of this 30 to 45 minute webinar. So for those that are watching and just see, is this what you want to get out of it? It's going to give you some helpful information so you can decide if you want to keep watching. So in a nutshell, this session is all about working effectively in a multidisciplinary team, which is a team made up of different health professionals working alongside each other to help the same client. So we'll start by talking through the roles of different health professionals that OTs may commonly work alongside. So this could include nursing staff, doctors, physios, speech pathologists, social workers, dietitians, psychologists, and exercise physiologists. They're the ones that we'll focus on in this session. Lots of other people that we could be working alongside as well. Once you know a little bit about what they do, then we'll go through some practical examples of when an OT might need to actually refer on to a different health professional, such as needing to refer to a social worker if we know that somebody that we're seeing will be needing some community services to ensure their safety with self-care when they go home, maybe from a discharge from hospital. And then we'll also talk about scenarios when we might be doing some joint sessions with other health professionals, such as maybe discussing some pressure care management strategies with a nurse or conducting a joint feeding assessment with a speech pathologist. So I'll give you a few more examples of what that might look like. And then next, we'll talk about some strategies that you can use to help the team work effectively together, such as making sure you're going to your case meetings prepared, doing your documentation in a timely manner. And then we'll also talk about the flip side, the tricky situations. So when there's a challenging scenario, so it could be that another health professional is providing a treatment and it's not evidence-based, what do you do? So the hot tip will be that if you're a student or a new grad, you shouldn't really be doing anything straight away unless you've had a chat with your supervisor about how best to approach the situation. But I'll give you some tips around how to actually do that as well. And then, as always, we'll do the wrap up. There'll be some homework activities for the keen beans and a sneak peek at what we're going to be covering next week. So if that sounds interesting, keep watching and we'll dive right in. So all the W's, the what, who, where, why, and when. So what are we talking about here? So today we're going to be talking about a multidisciplinary team. So this is a bit of a nice definition that I found. A multidisciplinary team is a group of professionals from different disciplines such as OT, physio, speech pathology, nursing, psychology, who work alongside each other to support a client, but they do so within their own professional scope. So this may be different to some other disciplinary type teams you hear of, transdisciplinary or interdisciplinary. Probably the main difference that you'll find is teams that work more as a transdisciplinary team. So in the multidis, which is what I'm going to be talking about now, is the physios do their physio role, the OTs do their physio role. So OTs do their OT role, and we might interact a little bit, refer to each other, maybe do joint sessions, but we're still very much staying within our own scope of our profession. There are some settings where there's more transdisciplinary teams. So there could be OTs and social workers doing very similar roles, not really working as an OT as such. So sometimes maybe in a mental health setting, you might be working as like a mental health type key worker, and it could be an OT doing the job, or it could be a social worker doing a job, and you're doing similar things, not necessarily working just within your own scope. So it's a little bit more fluid and can work really well in some settings. Other settings, you'll probably see more of this multidisciplinary, very separated roles. So that's what we'll focus on today. So who does what anyway? We'll go through a little bit more about that. So there's, I think, 8 different disciplines that I've thought I'd just give you a bit of a recap about. So we've got nursing staff to start with. So basically, if you're coming across nursing staff in a hospital setting, which a lot of students will be coming across on their placements, they're responsible for the day-to-day care of the patients in the hospital. So if patients need their medications, they need help to transfer, move around, they need help with their self-care activities. Generally, the nurses are primarily responsible for that. Now, in community settings, they may not be doing that day-to-day care as such. You might find that there's more specialist type nursing roles. So it could be that they're specialising and they just do wound care in the community, or they just do incontinence or continence type management. So sometimes you might see a little bit more specific roles. What you will see is like a hierarchy of roles. So there's different sort of more experienced nurses and more specialist roles. So you'll see this a lot, particularly in the hospital setting. So you'll start with like your AINs or your ENs. So they're like your junior nurses. So there's some things that they may not even be able to do in terms of maybe medications and things like that. Then you've got your registered nurses, which will probably be the bulk of who on hospitals. Maybe in nursing homes, you might see some RNs. Otherwise, it might be more those ENs, AINs as well. And I think is an enrolled nurse, AIN assistant in nursing, I think. Don't ask me for more details than that, but they're like your junior ones and they move up. And then nurses can actually specialize in different areas. So they can become like a nurse educator. They could become a nurse specialist and they specialize just in a particular thing, like I was saying before, like in maybe wound management or burns management, something like that. And then in a hospital, you'll also see a NUM, which is a nursing unit manager, and they're basically the boss of the ward. So if you're a hospital OT working on a ward, you want to make sure that you find out who that NUM is, how they like to run their ward, try and work along nicely with them, and it'll make your life a whole lot easier. They'll be more willing to work friendly with you if you're willing to fit in with how they like to run their ward, and every NUM will be a little bit different. So it's always worth finding out who it is, particularly if you're working across multiple wards. And basically, if you want to do any big changes to sort of big things happening within the ward, maybe offering like some sort of group sessions and things like that, always worth discussing with the NUM. If you're just wanting to give handover about a person's care, I've just done a showering assessment with Mrs. Smith. That's usually the nurse looking after them. So usually an RN or something like that. You don't bother the NUM with really big, important things like that if it's just like the day-to-day routine. So it's important to have a feel for where everyone sits in the hierarchy, particularly in hospital settings, so that you're actually giving handover or asking the questions of the right people so that you're not annoying the people that are maybe a bit too important to find out about the everyday things. Some will be lovely and won't mind. Others will actually be a little bit hard on you if you interrupt them at the wrong time. And it's similar with doctors, which we'll find out as well. So I think I've already covered that. They can specialize in things either within the hospital setting or in community settings as well. And one I didn't mention was, there's definitely specialist mental health nurses as well. The other thing about nurses is that sort of the next level above all the nurse specialists, they can actually become what's called nurse practitioners. And that actually gives them the ability to prescribe some medications, maybe to do some diagnostic type things as well. So they need to do more postgrad education to be able to get that certification. But basically, if you come across a nurse practitioner in the community or hospital, they know their stuff. So they're very experienced and knowledgeable. Doctors. So again, probably in the hospital setting, you'll see a bit of a hierarchy of different doctors. If you're working in the community, you may not actually see too many. You might hear your clients talk about visits to their GP. You may actually have a phone call to a GP if you've got a good GP that's able to help coordinate somebody's care. You may also have some conversations with specialists as well. Say you're working with a client with a progressive neuro condition. Sometimes we'll actually have conversations with neurologists as well. But basically, let's go to the hospital setting because that's the most common you might see. The doctors on the ward, there's a bit of a hierarchy. Basically, they're responsible for the overall management of the patient's care. So they decide if they're going to admit them to hospital. They also decide when they get to leave, and they can overrule some of our decisions as well. We need to be really clear about our reasons why we think discharging someone maybe isn't a good idea, but at the end of the day, we don't have the end decision. It does come down to the medical team. So you'll see that there's medical versus surgical. So it's sometimes funny if you look up some sort of humorous type things, there's sometimes a little bit of a difference in personality types in between the medical and the surgical doctors. And I think even if you work on the hospital, you'll see there's different ways that they do things. Often surgeons are on the wards first thing in the morning at 6 o'clock in the morning, if not earlier, doing their rounds, and then they're in surgery all day. So if you're working as an OT in maybe like a hospital orthopedic ward, sleeping people after hip replacements or fractures, and you think, oh, I'll catch the doctors, like the main surgeon on their rounds, unless you're getting there at 6 o'clock, you might miss them or later in the day. So a lot of the time, yeah, the surgeons are busy off the wards doing those sorts of things, but they will have junior doctors around that are doing some of the everyday activities. So I might talk about that sort of hierarchy now. So pretty much same with the nurses. You've got your junior doctors all the way up to your senior consultants that are the big bosses that actually admit the patients to hospital. And they may not necessarily do a lot of day-to-day work with the clients, but they make the big decisions. So all their junior doctors report back to them, and then they help make the decisions about the person's care needs. Depending on which ward you work on or which caseload, sometimes OTs will actually have face-to-face conversations with the very head bosses, like the specialists. So particularly in aged care or neuro wards where they really value the OT opinion, then often we'll have had lots of conversations with the direct neurologists or with the aged care geriatricians. They'll often come to the case conferences as well and talk through their patients. So you actually get to see them and have conversations. So as a student, can feel a little bit daunting or intimidating, but often a lot of them are quite lovely as well and will be very encouraging and be happy to hear your opinion as a student and give you a little bit of leeway if you're feeling nervous and things like that. They're the senior doctors. But generally, surgeons you may not see as often. They often will get their more junior doctors to come along to case conferences, things like that. So the junior doctors, you'll see things like residents or interns. Interns are probably like the lowest level, and the residents, they're the ones that you'll often see around the ward. They're filling in the medication charts, all those sorts of things for people. For the patients, if there's something, if you want to pass a message on to more of the senior medical team, then often we start with them and then they page the right doctor, get the right advice from the level, whichever they needed to talk to. On top of your interns, you've got your residents, and then you might have some registrars. So they're like your training to be consultants in a specialist area. So they're already starting to specialize in a little bit of a niche area. So they're becoming more experienced as well and can make more decisions. Sometimes they're doing, for the surgeons that are registrars, they might be doing surgeries as well by themselves, overseen by the main surgeon consultant. Just a thing to be aware of basically in a nutshell is that there's same thing, hierarchies. We'll often speak with the junior doctors, pass on our messages that way, but we do sometimes see the senior doctors as well and have conversations with them. Some other, now the rest I think are more allied health. So physios, often we'll get confused with physios. If you're in a hospital, often you'll have the same uniform or very similar to a physio, which makes it more confusing for our clients. But basically what they'll be doing is they're looking at managing and treating physical impairments and pain. They might look at somebody's gait or how they're walking and do the assessment and suggest some strategies. They can prescribe mobility aids. So this is where it can be a little bit of a funny overlap. So in hospitals, generally it'll be the physios that prescribe all the mobility aids. So walking frames, walking sticks, crutches. Wheelchairs maybe usually then flicks over to OT. But in the community, sometimes you'll actually be an OT and you're prescribing a four-wheeled walker or a walking stick. For someone that seems pretty straightforward, when it's a little bit more complicated, then usually we try and refer to the physios in the community. But they also do things like exercise programs. You might see orthotics. So if somebody has a foot drop in their ankle, they might do like a bit of a thermoplastic type. Yeah, it's an orthotic. It looks like a big sort of L-shaped splint. They can help fabricate those as well. Some physios, not all of them. They'll also do things like lifestyle modifications, help with positioning, pain movement, and they will also do some AT prescription. So mostly sort of those mobility things, but sometimes things like hoists or stand-up lifters or wheelchairs as well. So again, if you're an OT working in the community, you'll find out later on we talk about how to have effective teams. It's always important to know these are general roles that the different team members might take on, but everything could be a little bit different. So sometimes in a case, so the physios will do all the mobility aids. Sometimes the OTs may help. Sometimes the OTs will be the only ones that do like hoist prescription. Sometimes the physios help. So it's good to know what's exactly the roles in your particular setting so that you don't make assumptions or step on anybody's toes. But we'll talk a little bit about that a little bit later. Speech pathologists. So their two key areas are communication and swallowing. So in terms of swallowing, if someone has like weakness in their swallowing muscles, so often quite common for older people in aged care or neuro settings as well, they can't actually swallow safely and they start coughing. So the speech pathologists do swallowing assessments and they work out, do they need some modified foods like softer foods or fluids that are a bit thicker, those sorts of things. So that's one side. And then the communication side of things is looking at the actual like physical projection of voice. So if they have slurred speech or very soft speech, If they can't make any verbal speech, what other non-verbal communication methods do they have? And then for those that are talking, it's also more of that communication from a cognitive point of view in terms of like literacy and fluency, social communication as well. So sometimes we'll overlap a lot with speech pathologists in terms of how they're having communication, communicating with others in terms of those social relationships as well, plus lots of other places that we might overlap. So I'll talk about those in the next section. Social workers, so again, could be very different depending on what setting they're working in. Some of the key things that they might do is that they arrange support services. So in a hospital, it might be the OT that decides, yep, Mrs. Brown, she's not safe to do her cleaning or her shopping anymore when she first goes home from hospital. But then generally we'll hand over to a social worker, and it's the social worker that will decide, okay, which package of services will suit her needs best. Is it something that's going to be through her existing home care package? Does she need something additional when she first goes home from hospital? So we liaise with the support with the social workers to find out those sorts of things, but they'll do the kind of the logistics of setting it up. They can also help with financial or legal arrangements. So think things like paperwork, anyone dealing with Centrelink forms or pensions, and they need help with that side of things, they can help do all those things. And then the other part they can also do is like supportive counselling. So could be, again, within a community setting, some social workers may not do any of that sort of logistical paperwork services. They may actually specialise more in providing supportive counselling. So they're not formally psychologists or anything, but they do counselling in a different way. And that can be really helpful for us to know about. Sometimes we might refer some of our clients or the family members of clients as well if they're experiencing a difficult situation. And even social workers in the hospital wards, yep, they'll do services and paperwork and things, but some of them also really value opportunities to do that sort of supportive counselling as well. Again, when you get new to any sort of setting, find out who's available in your team and what they do in that setting, and try and use their skills and services as best you can to support your client. Dietitian, so they often will give like personalized dietary advice, and they're really good if so often with different medical conditions, it can be really important in terms of what the person's eating, because it can trigger different symptoms. If they're on specific medications, sometimes there's side effects with medications, and in terms of what they're eating when they're having the medications or when they're eating can actually have a really important impact as well. So sometimes they'll give some advice about balancing medications and their diet, or just how to use the diet to manage symptoms as well. So some of those sort of symptoms or issues could be things like digestive issues or constipation, if they've got lack of appetite, but also if we're coming across clients either in the hospital or community and they've had lots of unexplained weight loss, and often we'll get the referral because they've suddenly lost their function as well, or they've developed some pressure injuries, then it's always good to ask about that weight loss or weight gain. And if there's been drastic changes, then we might refer to the dietitians as well. They can help with some meal planning as well. So sometimes people, if we're working with someone on meal preparation and their ability to cook meals and things like that, if there's specific requirements, we might actually talk with dietitians or refer on to do that. They can help with those as well. Some other thing I haven't put on there, but in some particular caseloads, for example, I used to work in a burns unit, dietitians were really important because the person's dietary intake was a really big indicator in terms of how well their burns would heal and their wounds would heal. So this could also apply for people maybe that are in hospital with a long sort of chronic pressure injury, sorry. Their diet is really important to help the healing. Dietitians are really important to be involved. So they actually do they're good at maths. They do lots of calculations using formulas in terms of how much somebody's dietary intake actually is in terms of their calories, how many calories they should have to improve their healing and all those sorts of things. Yeah, if you need someone that's good with numbers, often dietitians are good with numbers for that reason. Exercise physiologists, so sometimes it's tricky because they may overlap a little bit with physios. I haven't seen too many, if any, exercise physiologists in a hospital setting as such. Generally, you'll see physios, but there are definitely more exercise physiologists in community, particularly in Australia with the NDIS. They do get funding to see NDIS clients. So they'll do things like exercise prescription, lifestyle modification as well, general strategies to improve overall health and well-being for chronic conditions. And like I said, they're experts in exercise. So basically to do all those things, modify their lifestyle or improve their health well-being, it's with some sort of exercise component. So it can be a little bit tricky to find out who should you be referring to if there's exercise physiologist. And it's a bit of a hot, heated debate that I'm not going to get into because some exercise physiologists say they can do some things and physios say, no, they shouldn't be doing that. assessment. It depends again very much on the setting that you're working in. So when you're ever trying to refer on or decide who to refer to, it's worth sometimes just having a conversation with the EP or the physio in your team or your local area and find out who maybe is going to be the best suited, because it can vary a little bit. And then the last person I wanted to tell you about were psychologists. So there's lots of different psychologists as well. So the general clinical psychology takes a lot of years to get through to get that sort of qualification, but then they can also go on and specialize something like maybe a neuropsychologist as well. And they do lots of cognitive testing. So psychologists in general can help somebody if they're trying to develop coping strategies for maybe some trauma, loss, or adjusting maybe to they've had a catastrophic injury like a spinal cord injury, or maybe they've got a progressive condition and they're slowly losing function. That can be a lot for clients to process and adjust to and accept. So they can help with those sorts of strategies and talking around those. Clients maybe that have behavioral challenging behaviors, they can be involved with doing those sorts of plans. So in the NDIS in Australia, you might hear of things like positive behavior support plans. So sometimes the people writing those plans are psychologists. They're not always, but often that sort of psychology background can be really helpful from that behavior point of view, looking at what's causing the behavior and what treatments are actually going to be most helpful to stop those behaviors from happening if they're harmful for the client. They also know a lot about cognition, learning as well. So that's where sometimes they can overlap with OT as well. And like I said, they can do specialized, such as being neuropsychologists. And they're the ones where if somebody needs really formal, in-depth cognitive testing to see their capacity to make decisions about their health or where they're living, then we might do some basic OT assessments and give an opinion, but we're not enough to really rule someone doesn't have capacity. Often it will need like that neuropsychology assessment to do that. And I've just put at the end that there's a difference between psychology and psychiatry. So psychiatry is more the medical team. So they're medical doctors, whereas psychology are more like allied health professionals. So the main difference being that there's probably lots of differences, but for the student level understanding, the psychiatrists are the ones that will actually prescribe medications for things like mental health conditions. They're the ones that will diagnose most conditions and actually get it formally recognized as a diagnosis. You'll see them definitely in inpatient mental health hospitals. There's sometimes even in general hospitals, but usually don't have a whole ward that they're working to look after. They might do more consulting if there's people admitted with psychiatric conditions. Hopefully that's in a nutshell gives you a little bit of an idea, and I've started to touch on where we might actually work with these sorts of professionals and refer on, but I'll give you a few more examples now, not for everyone, but just for some of the key ones that you're probably going to come across as a student. So first one we've got is the OT and the physio. So some examples where we might refer on or where we might do joint sessions. So if we're maybe working in the community or working in the hospital, good thing to know about physio is that if you're in a hospital setting, in a lot of wards, they may actually be what they call a blanket referral. So I think I've mentioned this in some of the previous hospital webinars. Basically, that means that everyone admitted to that ward or with that particular condition will be automatically seen by that health professional. So for physios, often like aged care, that'll be a blanket referral. Orthopedic wards, blanket referral, just means that physios will see everyone. So if they're already seeing the client, then we don't need to refer onto them. But if we're working in a different ward where they're not automatically being referred to everybody, these are the things we might be looking for. So a decrease in the person's mobility, they've suddenly had a loss of strength or their endurance that's impacting their function. Or if we're doing like a functional mobility assessment, we're thinking, oh, your walking pattern seems a little bit odd. It's a little bit ataxic, or it's a little bit unsteady, or they're leaning to one side, or they've got some sort of limp that nobody's diagnosed. Those sorts of things we might actually think about. It could be worth having a physio review. And similar if it happened in the community setting as well. Now, there might be times where we do some joint sessions. So some practical examples, and it's good to know this as a student so you can think about where it might be helpful to either go and observe a session with a physio or even be involved yourself as well, because it can actually give us really helpful information. And again, I'm talking sort of hospital as a basic example to start with, but definitely we can do this in a community setting, working with people like aged care clients or NDIS clients. Sometimes it just gets a little bit trickier in the community to do these joint sessions because you may be an OT working for one company and the physio works for a different company. So you've got to try and match up when you're going to do the appointments, make sure that the client's happy to pay for both visits to happen at the same time, not going to be too overwhelming for them, all those sorts of things. Whereas in a hospital, it's a little bit easier. We can often be there on the ward at the same time and just get it done. So functional transfer assessments might be if we're thinking somebody's maybe, an example could be that they need two people to help transfer. Maybe they're used to just standing up with one person's help or two people's help, or they're using like a stand-up lifter, and we're trying to work out, okay, are they still safe to do that, or do they need some sort of like full sling lifting hoist like in the picture? And that might depend also on the person's sitting balance as well, or sort of their range of motion in their hips and their knees and things. So physios are really good with lower limb anatomy. Some are really good with upper limb as well. Sometimes we'll talk about in the next one, the OTs will do more upper limb, but anywhere where we're trying to look at somebody's body positioning, their ability to transfer, if it's that little bit trickier, and definitely when it's needing more two people, then we can do a joint session and get both perspectives. Another example could be neuro rehab sessions. So often people either on an acute stroke ward or if they're in a rehab ward, again, can happen in the community. Sometimes it's really helpful to do a bit of a joint session at the same time. It might be that one profession is leading the session and the other, so the physio's leading the session, working on maybe sit to stand type practice, but the OT is watching at the same time or providing tips about that left neglect is still an ongoing issue. How can we manage that and try and build that into the physio session as well? In terms of upper limb management with neuro rehab, you'll find that sometimes some hospitals will be very strict, whereas, if there's been hemiplegic changes or changes with somebody's function because of a stroke or neuro condition to their arm and hand, the OTs handle that. Whereas in other settings, it could be actually that the physios will still do it if it's the shoulder, but then the OTs take over for the hand. There's no strict rules that say that if you've done an OT degree, you can only look at the elbow down, and there's nothing saying that physios can't look at the hand as well, but it very much depends on the setting that you're working in. And it'll be varied. So some hospitals or community teams might be really strict on who does what, others are a bit more flexible. So always just have that conversation with your supervisor to find if there's any unwritten rules about who does what, or whether, how you all work effectively together. OTs and social work. So again, we might be referring on to them. Like I said, if we're seeing somebody on the ward and we're like, they're going to need some help when they go home, we might work out what help they need. Then we get the social workers to help arrange the logistics and work out which package of services is going to suit them best based on the information we've given about their function and whether they need some ongoing just support with services or maybe some ongoing OT physio as well. Anything to do with packages from hospital in terms of services, often it will be the social workers that organise that. If you've come across anyone and you've suddenly got caught up and they've got, can you help me fill in this Centrelink pension form? Can you help me do this form? Unless it's directly related to some sort of OT functional issue, generally social workers are really good with that side of paperwork, follow-up, making sure that they've linked in with the right people, done the right form, all those sorts of things. So always worth asking for a social worker's opinion if they can help with that side of things. And like I say, if you do come across any of your clients that need a bit more support and counselling, if it turns out that all of your sessions are more turning into just listening and providing empathy and support that way, some OTs definitely can do that as their primary role, but it could be that if you've only got a limited amount of funding to prescribe some equipment, that's all that you really need to focus on. But you can see that your client also needs that supportive counselling. It could be looking at, okay, is there a social worker or someone that could also do that instead? And then some things where we might do joint sessions. So in a hospital, if somebody's got a really complex discharge situation, so lots of family dramas, or maybe their care needs are going to be really high, often we'll work really closely with social workers to try and have all those conversations, keep everyone on the same page. And that involves some family meetings as well. Often the social workers will be responsible for coordinating those. They'll say, yep, I've spoken to the family, they're going to be here this date. When can you be here? Make sure, we'll all have those conversations. So again, check with what happens on your hospital, but if you're feeling like the whole team needs to come together, lots of family members are giving you different information or conflicting information, sometimes it's good to get a social worker involved to help manage that dynamics as well. And if you're having somebody as part of your sessions, you're talking about, we need to prescribe this equipment, and you know that it's because they've got a palliative condition or that their function is going to deteriorate, but maybe the family's not really accepting about that, or the patient's not really accepting, or there's lots of other concerns. And that's where it might be like that supportive counselling role of the social workers could be really helpful as well, to be another person to have those conversations. Another one could be OTs and speech pathologists. So again, if we're working with a client, we notice that they're having trouble with their communication. So maybe their voice is very soft and it's impacting their ability to be heard, and that's new, or they've got some slurred speech, so any changes to their voice. even if we see somebody like in a hospital come in from the community, maybe they've got a disability and they normally have a particular way of communicating via like AAC, which is their augmentative and alternative communication, like some sort of iPad device or other things, or sometimes it's even more simple, just like a board that's got different letters or different pictures that they point to. Sometimes if we notice something like that is actually missing, we might get the speech pathologist involved to work out what's happened there. Is there something more important that we need to know about that has been missed in that handover or into hospital? Sometimes there's also that someone comes to hospital and they just haven't actually had any allied health input in the community, but they really could benefit from having some sort of review of their communication. Then we can refer to the speech pathologist, even in the hospital, and they can work out, do we need to do anything right now, or do we need to refer to a community speech pathologist to look into that? And definitely if you're already in the community and you're noticing any of those things, swallowing is the last thing as well. Someone suddenly says, oh, I've been coughing a lot on my tablets, or when I have a drink now, I cough. Coughing is often the big indicator that maybe something is happening with their swallowing, particularly if it's happening a lot or after every time they eat and drink, then definitely worth considering a referral to the speech pathologist. We can also do some joint sessions. So example in that photo is like some feeding assessments, often OTs and speechies in like a pediatric setting, in particularly an outpatient, like an NDIS type funding model. We might both be looking at kids that are picky eaters or that have trouble with their diets and very restrictive eating. So we might actually work together because there's an overlap in terms of the OT and the speech pathologist role there. We can work together to prescribe AAC, which is that augmentative and alternative communication. So that's things like different iPad type devices. Sometimes what is happening is that the speech pathologist will work out which communication method is going to work, but then they actually need the OT involved to help set it up on their wheelchair or to work out what switch is going to activate that communication device. So often we work really well together to find the best outcome. And sometimes we might have a bit of overlap in terms of cognitive assessment. So we might be doing some sort of assessment of their cognition, like a pen and paper type test, like a mocker or a mini mental or an ACE that we spoke about in a previous webinar. We might be doing that and think they're scoring terribly, what's going wrong here? But then when we do a functional assessment, we don't see those huge difficulties. Sometimes it can actually be that there's some sort of language change or deficit, particularly in neuro wards, something to do with the way that their processing language has changed. So getting them involved to help with that side of things can help clarify some of those tricky things we might be seeing in terms of cognition as well. And then the final example we've got is OTs and nursing staff. So if we're working in a ward and we suddenly see patient looks sudden change, they seem unwell, they report that they're feeling unwell, the nursing staff are definitely the ones that we will go and see. Generally, we don't do a referral where we do a formal request for them to come and see. We just go and find them on the ward and give them that handover in terms of what we're seeing and what we would like them to come and check. In other settings, and it could be within the hospital setting or it could be in the community, we might be doing something like toileting assessment. So you can see there's some joint sessions here. So in some instances, we might just decide, yep, the issue is more like a medical issue or a nursing issue. We'll refer to them to handle it. And sometimes we'll actually work together in the actual sessions together to do things like continence and toileting. So if someone's having difficulty with having lots of accidents or they've got pads, but they're not really catching everything that they need to, and it's still causing issues on their bedding and things like that, then sometimes we can do a joint session to talk about toileting. So what's the person's functional ability to physically manage getting pads up and down? And the nurses will be able to give an opinion on, has medically everything been optimized in terms of their continence so that we're not making it harder for the client than it needs to be. Wounds is another one, and that can overlap with like pressure care assessment. So someone even in the community has a pressure injury, the nurses might be coming out and keeping on top of the wound care and giving advice about that. But then they also have lots of knowledge about some of the cushions and mattresses as well. And we might overlap and problem solve, work out what we think is going to be best. And then one of us usually the OT will do the prescription and request for it. But often wound nurses will be really knowledgeable about pressure care as well. Could be other things, like I said, the mental health side of things. So if someone's had some sort of mental health crisis in the community, is it a mental health nurse that's available to them? Sometimes if they've got a chronic mental health condition, they actually are well known to a team. And often it might be a nurse that's one of their main contact people within that team. So we might refer back to them. And the other one I've got there is a joint session, so it's for carer education. So sometimes in a hospital ward, if someone's going to be going home and now suddenly they need the family going to be doing maybe lots of really hands-on care, so giving them a bed wash, using toileting pans and bed pans and things like that, we often work together. So the OTs will be the ones that say, okay, you're going to take your loved one home now, but provide all this care. We'll help organise a hospital bed, a mattress and hoist. We'll provide some education about the hoist. But then sometimes it'll be the nursing staff that actually will give that education about here's how you do a bed bath, here's how you use the bedpan and do all those sorts of logistical things. So we work really closely together to make sure that we're giving similar information and that all up, we're covering everything that needs to be covered. So hopefully that's given you a few more practical examples of how we might interact or refer on. And like I said, they're very general. It'll change in different situations. So if you're watching this as a student or a new grad, hopefully the benefit will be is that you'll have a supervisor who you'll be able to have a chat to about some of these things if you're not quite sure if you should be referring or where you should be referring. But having a little bit of a background could be helpful. And then just to finish off, how can we work well together? Firstly, think about basically any strategies that are going to promote good teamwork within any team is probably going to be helpful for a multidisciplinary team. But within healthcare, some of the key things I'd suggest is to know the roles of the team that's around you so you can refer appropriately. Or if you're giving some sort of clinical handover, that you're only giving them the relevant information. So you're not going to the nurse and telling them all the outcomes of something that more a physio will be interested in or something like that, or talking to the physio about the person swallowing. They don't really care so much. They might be more interested in how their walking was that morning. So knowing what the roles are so you can give that clear communication is really important. Also, really clarifying from the setting, like I've said, all the way through this, respecting boundaries in terms of knowing in different settings, some will be really strict, like OTs only do this, physios do this, or, there's the psychologist will take over this part of the cognitive assessment, the OTs start with this bit. Sometimes it'll be really strict and other times it'll be a lot more fluid. So always just have those conversations with your supervisor about if there are any clear boundaries that you really need to be on top of and just respecting each other's professional opinion. There's lots of meetings. Generally, when there's a multidisciplinary team, you'll see it a lot in the hospital setting. So often there'll be like a weekly case conference. In some wards, there might even be a morning meeting every day where you go through and, yep, who's going to be discharged today? What's the priority? So you want to make sure if there are those meetings that everyone attends, that you're going prepared. So you don't turn up and go, oh, I'm not sure. You want to be a really helpful person that gives helpful information to the right people. If you're working in the community, sometimes it's trickier. It's a challenge I've seen since moving from the hospitals to a community setting. It's not as normal to have really regular conversations, particularly because we're working across different employers. So an OT works one company, physio a different one. So trying to actually be proactive and trying to organise those conversations or those meetings if you think it's really important for your client situation is a really important thing to do. If you're doing any sort of documentation where other people are going to be reading it, so very big one in the hospital setting, make sure you do your documentation as promptly as possible. So don't do your initial assessment about a client that's going to be really helpful for someone's discharge planning and then don't write it up till the next day. Not really helpful if the social work, the physio want to know, okay, do I need to do anything now? What's going on? So try and be really prompt with your documentation. And then the handover I've touched on, but just making sure that if you are having conversations with any of these health professionals, practice something. So remember, there's a whole webinar on using the ISBA format to be really clear and succinct and only giving them the most relevant information to what they'll be doing with the client, what their role is. Now, if there is a bit of a tricky situation, so some examples that I can think of that I've come across either myself or I've seen some other junior people report, could be that you've maybe come across a really old school clinician, we'll say it's a physio or a speechy, no offense to any of those professions. Maybe they've been doing something the same way for a long time and you're like, oh, actually I've learned at uni that that's out of date now. There's new evidence that suggests that's actually quite harmful and we shouldn't be doing that anymore. And if they're doing this old way of doing things and the new way, and you're giving conflicting information, that can be really challenging for the client, then also in terms of, okay, how do I navigate that? So that's a tricky situation. Or it could be that sometimes, particularly as a student or a new grad, you're in a team and suddenly you get pushed around and become everybody's go-to person for the basic, can you go and get that from the gym? Can you go and put that away? Instead of actually being respected as a team member with your own opinion. So they're just some examples where it could be tricky. What I would suggest that if you're a student or a new grad though, hopefully there won't be too many situations where you'll be encountering these scenarios without some sort of supervisor that you can turn to for some support about how do I address this is the issue that I'm seeing, what should I do? Ideally, assess the situation as best you can in terms of, okay, this is the issue that I'm seeing. And so you can be really clear in your reasoning when you actually then talk to your supervisor about what the issue is. Now, if you're seeing something like, I just don't feel right, I can't really put my finger on it, but this is what I'm feeling, it's okay to go to your supervisor without a fully formed opinion of this is what the issue is and this is what I need to do. But if you can think through that, then that's really helpful when you go to your supervisor. So then they can just say, yep, that's good, or no, don't do it that way, rather than having to tell you everything to do from scratch. So see how you go depending on the situation. But often it's why it's important to go to supervisors, particularly if you're a student that's just coming into a placement for a short time. There's sometimes really big personalities, I'll call it, in different teams where maybe it's the physio or a speech there's someone that's been in the ward for 20 years and they're used to doing it my way or the highway. They like to be the boss, they like to be in charge. And if you came in as the student OT and suddenly said, oh, I don't think you're doing that, probably what could happen is that you're actually going to make your life really difficult. Now, I'm not suggesting that's right or that they should be allowed to keep bossing people around, because sometimes it is bullying, or that they keep doing things the wrong way. But it's sometimes in terms of picking your battles, in terms of self-preservation as a student and how much of an impact you might actually be able to make. So if you're feeling something where you're feeling uncomfortable, you're seeing something that's not right, go to your supervisor and your supervisor will be able to say, okay, yep, this has been an ongoing issue. In the background, we're working on these sorts of things. This is what I'd like you to do just to be able to get through this placement. So sometimes it's just a matter of getting through this placement. So yeah, just keep in mind some of those things. If you see things that aren't quite right, it's not necessarily your responsibility to fix everything and change the world in your 2-week placement, because sometimes it's bigger things going on that you may not be aware of. And that's why it's really important to have a chat to your supervisor before you just launch in and start to challenge things. Sometimes you think, oh, my supervisor's going to expect me to show that initiative and really speak up. They may not. They may want you to just clear things with them first. So always just check. This is what I'm thinking. This is what I'm thinking I might do. What do you think before you go ahead? And just to make the situation more difficult for yourself than it needs to be. Because the other flip side is you may look at it and go, oh, on the surface, they're doing something completely wrong. That's out of date. We don't do that anymore. But maybe there's actually a lot more to it in terms of that client that's been in the rehab ward for many months. And there's a reason that they're doing it this way, which if you knew that, you'd be like, yeah, that makes sense. So if you just charged in thinking that on the surface level, they're doing things wrong, I know the right answer, and then you say that, and there's all this other stuff happening, you could actually, embarrass yourself a little bit because they're like, actually, no, you've missed all this. So I say those conversations with the supervisor can be really helpful just to fill you in on things that maybe you're not aware of as well. So what can you do? Prepare yourself firstly. So know the roles, the personalities in the team. Is there someone that maybe is not good to go and have a confrontation with? Make sure your supervisor is actually aware of what you're thinking is the issue, what you're planning to do, and get their okay before you just take action and do it. And then if there is something where the supervisor, no, that's a great plan, I think you should do that, they would be open to that sort of feedback, then you might still feel quite nervous. So if there's an opportunity to role play that with your supervisor, that can be really helpful as well. So the reason it can be helpful is often just be really clear in your own reasoning about why you think it's wrong, or why you think they need to do something a different way, or why what they're doing is contradicting what you've told the client to do. So actually having that talk through with a supervisor can make you really clear and more confident before you actually go into that conversation. So like I said, these have made it sound like a really huge thing. Hopefully you won't come across any of those really challenging situations as a student or a new grad, but if you do, that might be a helpful starting point in terms of what should I do. And just to wrap up, so again, what was your biggest aha moment? Was there something here that you didn't realize another allied health professional did, or how to tackle those challenging situations? If there's something straight away you think, oh, I need to go and actually do more research about that. Or if you're on placement at the moment, you're like, oh, there's a speechy there, but I still don't actually fully know what they're doing, even though they're seeing the same client as I. But it's really valuable to go and say, can I just tag along and see your session, and then ask some questions afterwards for your own learning about their role so that you can work better together. Now, as a bit of a homework task, what I've got is like a little bit of some questions, really. So I want you to choose like a clinical setting. So it could be an orthopedic hospital ward, or it could be in a community setting working with aged care clients, and then basically do these things. So name 3 other professionals who are in that team, or if they're not already in the team because you're in the community, who should be involved, who else could be relevant for that client now that you know a little bit about them. Outline what their role is, and list one example of when you might actually refer to them or actually do a joint session. So if you've chosen orthopedic ward, physios are one of the people on your list, what's one example of when you might do a joint session with the physio? And then the other side is just have a think through that challenging situation. So if you're the OT on that physio, on that orthopedic ward, and then you have an issue with the physio, maybe a bit of a clash, what would you actually do to address the issue? What's the key steps that you might follow? So hopefully that might be helpful as a bit of a reflection and consolidation of what we've covered today. If you've got any questions, remember that you can use the discussion board. You can email me directly, or every 4 weeks we have our Q&A, so you can drop the question in the spreadsheet or just let me know and come along live as well. Next week, we're going to be covering basic database searches. So probably flipping to a little bit more academic, maybe a little bit more of what you'll actually come across in university life when you're trying to either find journal articles for an assessment, but we definitely should be still using these skills once you're a practicing clinician. So even if you're a new grad and you're like, nope, don't need it, don't do assignments anymore, you should still know how to do a basic database search so that you can stay evidence-based in the treatments that you're doing. I'm going to do it in the least painful way possible, hopefully, and show you just some really practical examples of what you're looking for in these database searches. So hopefully that could be helpful for you as well. All my contact details as usual, but if you do have any questions, get in touch, and otherwise I will see you at the next session. Thanks for coming. Stop the recording now.
Thank you.